Hello everyone, my name is Arun Sebastian. I'm a PhD student at the University of Sydney. Today I'm going to talk on the topic characterization of upper airway collapse in obstructive sleep apnea patients using Snore signal, a clustered analysis approach. In this study, we investigated if audio signal recorded during hypopnea events can assist in identifying the site of collapse in upper airway. For this, we use an unsupervised machine learning algorithm to form clusters using Snore data and verify if the clusters are associated with the site of collapse. Obstructive sleep apnea, or OSA, is a highly prevalent sleep-related breathing disorder which is characterized by repetitive obstruction in upper airway. The common treatment for OSA are continuous positive airway pressure, or CPAP, oral appliance, and surgery. CPAP is considered as the first-line therapy, but low patient adherence and acceptance make it less effective in real-world application. Oral appliance provide an alternative treatment for patients who cannot tolerate or refuse CPAP. But the catch is that oral appliances are only effective in some patients, and it is difficult to predict which patient will respond well to the therapy. Even though various treatment modalities are available, the key unresolved issue of OSA treatment is the inability to predict the most appropriate treatment. Studies have demonstrated that determining the site of upper airway closure is an important determinant of treatment outcome. Various studies suggest that identifying patients with tongue-based collapse would assist clinicians in choosing better treatment using oral appliance therapy. The gold standard method for identifying the site of collapse is endoscopy or a pressure catheter, which is passed via nose into upper airway during drug-induced or natural sleep. Unfortunately, this method is not suitable for clinical practice due to its invasive nature and time expense of the test. Recently, researchers have demonstrated that shape of nasal pressure waveform can be used to identify the site of collapse. But the main disadvantage of this study is that airflow was measured using a sealed mask and a low level of CPAP were used to maintain stable flow limitation. Recently, we introduced a classification method to predict the site of collapse using Snore signal during hypopnea. A limitation of our study was that we have not used a gold standard method to find the site of collapse, and our indirect method may introduce some labeling errors. Also, the supervised method required a training set to tune the model. Therefore, in this study, we propose an unsupervised algorithm using cluster analysis to form the clusters using Snore signal without any prior knowledge and verify if the clusters are associated with the site of collapse. Our subject population include 58 patients who attended a full night sleep study using PSG at Royal North Shore Hospital, Sydney, and received a diagnosis of OSA. The patient's respiratory sound signal were recorded simultaneously with PSG data using a microphone, which was placed on the ceiling about 1.5 meters above the patient's bed. The probable site of airway collapse was determined by an indirect process by manual analysis of shape of airflow signal during hypopnea using the reference pattern shown in the figure. Using the airflow reference pattern, 3 sites of collapse, lateral wall, palate, and tongue-based, were determined based on the flattening or scooping of airflow contour. This labeling was used for external cluster validation to evaluate the performance. We extracted 50 identical features from each hypopnea event, consisting of various time and spectral features considering their potential link to upper airway physiology. The time domain features consist of energy, entropy, and zero crossing rate. And the frequency domain features consist of first 3 Forman frequency, 13 Mel frequency subsystem coefficient and its first derivative, spectral entropy, flux, roll-off, and centroid, spectral chroma feature, fundamental frequency, harmonic frequency, and pitch. We developed an unsupervised cluster analysis using a k-means clustering with the features extracted from Snore signal during hypopnea event. A systematic evaluation was implemented to find the optimal feature set and optimal number of clusters using Chilli coefficient. Chilli analysis is a measure of internal cluster validation, which measures how well a data fit into its own cluster compared to other clusters. The Chilli plot provides a visual way to assess the parameters such as number of clusters and number of data points in a cluster, and its value ranges from -1 to 1. Internal and external cluster validation was done to evaluate the performance of the system. Internal cluster validation was used to find the tendency of observation to form the clusters without any reference, and external cluster validation was used to compare the results with externally provided class label. Coming to the method, the first step in the cluster analysis is estimating the optimum number of clusters in a dataset without any prior information. In order to determine the fitness of data point into a particular number of clusters, we use Cistulli coefficient to find the optimum number of clusters. For this, Cistulli coefficient for each feature and all the features together were determined by varying the number of clusters ranging from 2 to 6 and finding the cluster number with maximum Cistulli coefficient. The next step is the feature selection process. Using the optimum cluster number, we evaluate the mean Cistulli coefficient and Cistulli plot for each feature and then discard the features based on the thickness of Cistulli plot. In the next phase, we rank the features using a Laplacian score, which is a method to rank the features for unsupervised learning. In the final phase, we evaluate the performance of the system with the selected features. The result showed that the optimum number of clusters was 2 for majority of the features and with all the features combined. Therefore, in the next phase, we evaluate the mean Cistulli coefficient and Cistulli plot for each feature using a 2-means clustering. We select 26 features based on the mean Cistulli coefficient and Cistulli plot. This is done by discarding various features if the number of data points in a cluster is greater than 60%. The left-hand side figure shows a good example of cluster analysis. Both the first coefficient of MFCC and spectral comma features had a uniform width of cluster with a mean Cistulli coefficient of 0.77 and 0.72 respectively. The right-hand side figure shows an example of Cistulli plot for the features that did not fit well in the cluster. Even though the zero crossing rate had a high mean Cistulli coefficient of 0.98, the width of 2 clusters was uniform. For the energy feature, mean Cistulli coefficient was 0.73 with a large number of outliers, which resulted in a few negative coefficients values in cluster 1. In the next phase, we select the first 17 relevant features from Laplacian score, which gives the maximum Cistulli coefficient. The performance of the internal cluster validation showed that the data has a good tendency to form clusters with an optimal cluster number of 2 and a mean Cistulli coefficient of 0.79. The figure shows an example of Cistulli plot with the selected features. For the external cluster validation was done to evaluate the performance of the model using the annotations. In this part, we aim to determine the correlation between the cluster and the site of collapse in upper airway. As the optimum cluster number is 2, we try to relate the cluster with tongue and non-tongue related collapse, which is an important factor in predicting the oral appliance treatment success. The performance showed that the model achieved an overall accuracy of 62% when we assigned the label as tongue and non-tongue based collapse for cluster 1 and cluster 2 respectively, which is similar to the supervised method. Also, we try to relate the cluster with the predominant site of collapse if more than 60% of total events comes in one cluster, while the cluster 1 is labeled as tongue and cluster 2 is labeled as non-tongue. It shows an accuracy of 68% while it was around 80% in supervised model. Even though the overall accuracy is less, the main advantage of cluster method is that it doesn't require any training set to tune the model and doesn't require any labeling method. In conclusion, this study proposes an unsupervised machine learning algorithm using k-means clustering to find the correlation between cluster generated with snoring data and the site of collapse in upper airway. Performance of the internal cluster validation showed that the tendency to form the data to form 2 clusters with a high Cistulli coefficient. Further studies are necessary by combining the various pathophysiological factors and snoring utilizing advanced cluster model and feature selection method. Thank you all for your attention. If you have any questions, please send an email to arunsebastian@sydney.edu.au. Thank you.